I'd like to welcome you to the 21st Annual Wall Street Comes to Washington Conference. I'm Paul Ginsberg. I'm Director of the Center for Health Policy at Brookings and Director of Public Policy at the USC Schaefer Center for Health Policy and Economics. Many years ago, shortly after beginning the Center for Studying Health System Change site visit studies on changes in financing and delivery of care, I perceived how poorly informed policymakers were about what was happening on the ground in healthcare markets. I also perceived that Wall Street analysts were conducting their own research on these issues to inform their investor clients, and that policymakers also could benefit from the analysts' broader market perspective. So after convening a meeting with analysts in New York to discuss market developments, I invited them the next year to come to Washington to have these discussions in front of a policy audience. Now this annual conference has exceeded the lifetime of the center and has moved with me to USC and now also to Brookings. So I'm delighted that Jane Koskina's Ted Giovannis Foundation for Health and Policy recognizes the value of the conference by sponsoring the event for its fourth year. Through research and projects like this conference, the JKTG Foundation hopes to foster discussion about cost reduction, expanding access to care, and improving quality. The conference's main purpose is to give the Washington health policy community insights into market developments that are relevant to policy through a different source of information, equity analysts who advise investors about which publicly traded companies will do well and which ones will not. Along with a thorough understanding of healthcare markets and the companies they follow, all three of our analysts today closely follow public policy because the implications for publicly traded companies are so profound. They likely will have comments about the market responses to policies expected from the Trump administration and the Congress, comments which may be helpful to those crafting these policies. So the format of our meeting will be a roundtable discussion based on a series of questions that have been shared with the panelists in advance. We'll have two opportunities for questions from the audience, the first before we take a break at 10:30 and the second before we adjourn at noon. Note that the analysts are not permitted by their employers to answer questions about the outlook for specific companies. And a transcript and the webcast of this conference will be available through the Brookings and the JKTG Foundation websites later this week. And before you leave today, we'd appreciate it if you could take a moment to fill out the evaluation, the pink paper on your seats, and leave it on the table outside the room. We have a terrific panel this morning. They're all veterans of this conference, have done very well in the past. Matt Borsch of Goldman Sachs, Anna Gupta of Leerink Partners, and Cheryl Skolnick of Mizuho Securities. You have their bios in your materials that you picked up. So I want to jump right into the discussion, asking a question of the analysts that's different from most of the questions I ask, which are about markets. But I thought it's a good way to get us into it. And it's really about investor reaction to the election. And I want to ask them to discuss how investors in healthcare have reacted to the election in terms of stock movements in different industry segments. And things might look different in a few weeks or months, but if investors are right, what are the actions companies might actually take in terms of a different public policy environments? Who would like to begin?
I could start here. The first thing I think is the very obvious, the Medicaid managed care organization company, Centene and Molina in particular. Better? Okay. The Medicaid companies and the acute care hospitals saw a big sell-off. Not surprising. I think most of us would interpret this big surprise, if you will, in the elections as a likely repeal of the ACA. The replace is quite unclear. Both those sectors saw enormous tailwinds from the Affordable Care Act, the hospitals with volume and with bad debt, and the Medicaid HMOs saw a lot of volume and top-line tailwinds as well. So they sold off. Further away, yeah, sorry about that. Okay. The Medicare HMOs also started to see a lift, probably not as obvious initially, but then they rallied quite a bit. So Humana has seen quite a move since now it's reached almost $200, from 170 or something before the election. So a huge move, an expectation that the CMS from a Republican administration would be far more lenient, will deregulate, be less harsh on risk coding intensity, benchmark payments, all of that. So we saw a rally there. And most recently, I think the diversified HMOs have also now seen a move up. We've seen United have quite a big move, reached an intra-year high, and Aetna and even Anthem as well. And I think that's coming mostly from the expectation that there'll be a repeal of the health insurance fee, the tax. Firstly, all of the industry taxes, but benefiting the insurance industry quite a bit from tax reform, specifically related to the ACA, and then broader tax reform, which is likely to drive down their tax rate and bring some tailwinds as well.
So let me jump in here. So at about 10:30, when Hillary Clinton was struggling in Virginia, I started writing my note. And at 1:30, I sent it through when it was clear that Michigan was very pink. I like pink, but I don't like what happens to my hospital stocks, and I don't like what the outlook is for the healthcare sector generally when we have this kind of an unexpected outcome. And by 4:09 a.m., I downgraded the entire sector, both hospitals, managed care, and post-acute. The problem that we face, and Anna has outlined a lot of what investors may believe or don't believe, but certainly in the first hours after the election and results were blindingly obvious to anyone with a television, it was very clear that the right answer to the question, what will happen, is we don't have the foggiest clue. And to pretend otherwise, I think, is not being fair to our investment community. We do not know. The administration hasn't been set yet. We don't even know who's running Health and Human Services. We don't know who the new administrator is for CMS. We don't know what implications new tax policy will have for healthcare. As Anna mentioned, some things may go away, some things may stay. Then we get sort of the backpedaling. Well, gee, maybe we don't want to take 20 million people's insurance away, even though they potentially, some of them voted for it. They told us they don't mind, so maybe we can take it away, or maybe we can't take it away. This is the kind of dialogue that creates tremendous underlying uncertainty. And what you're observing is the market convincing itself that everything will be fine for some sectors, or maybe not as bad. So the way I like to describe it is normally, in a normal election cycle, you would have seen the Republican Party platform around healthcare coalesce around a plan. Could have been the better way, could have been some other plan, but there would have been a platform, a group of concepts that were more than just ad hoc, well, we'll do this, maybe we'll do that, throw things on a piece of paper. So we would have had a normal distribution of outcomes around that midpoint of the distribution. One standard deviation on either side would probably have had the right answer of what our healthcare system and policy will look like in the next 4 years. But we don't have that. So in essence, what you've done is you've introduced randomness, statistical chaos, as it were. And that chaotic state is kind of, I describe it as like a colonization hex, because once you shoot that marble into the colony, it changes the color of all the other marbles around it. And that's exactly what you're seeing happening in the marketplace right now, is that once there's a notion of something that people can hang on to, it will change the perception of everything around it. But when you don't know what the shape of the distribution is, all you can do is identify what the endpoints are, because you don't know what the midpoint is, and you don't know any of the probabilities around the likely outcomes. So what we do know is it is unlikely that anything will be better than what we have today from a provider perspective, from a hospital perspective, from a Medicaid managed care perspective. So if we preserve the level of Medicaid expansion as it is today, it's probably as good as it's going to get, all right, as an example. So all we can do is measure the worst case and measure the best case and get comfortable around the worst case and the best case. And investors are starting to do that work. I had an hour-long conversation helping somebody this morning work through what's the worst case, what's the best case for hospitals, for managed care, for others. But the problem that we face here is that the ACA, as those of you who understand it know, is much more than just the coverage expansion. So we have this whole value-based payment thrust that was born out of regulations contained in the ACA and built on since then. Has that train left the station? Have payers and providers, have primary care physicians so integrated the premises of value-based care, of patient-centered care, of all of the strides we've made in that direction into their practices? If so, then companies like Optum, which is part of United Health Group, which is fundamentally built on the promise of transforming and fixing healthcare, will they continue to have this acceleration in demand, or will the new administration, for example, back off the promise to move X percentage, whatever it is going to be ultimately, of Medicare fee-for-service to value-based care? Or will Medicare fee-for-service disappear in a forest of premium support? Now you see where I'm going here. This is going to be much more than just simply block grants. Medicaid expansion, yes or no. Exchanges, yes or no. There is much more there. So what you're seeing right now is a desperate attempt to make certainty or surety out of uncertainty, when the right answer is it is tremendously, in my view, tremendously uncertain right now. But we're investors. We can't not have an opinion. We can't not have a position, although portfolio managers can avoid the sector altogether. And so we're rationalizing. And in that rationalization lies danger when we know nothing more today than we did a week ago.
Yeah, maybe just a little brief add-on to both of those good summations. So I definitely agree with Cheryl that there is a high degree of uncertainty here. No one can dispute that. You know, our job to a certain extent as analysts is to try to predict the future. And I think, you know, looking at the current situation, investors are making directional bets here. They're making directional bets that we're going to see more commercial market deregulation, and that may, you know, go beyond the outlook for the individual market in the ACA exchanges and encompass areas like small group that have been pretty significantly impacted by the ACA regulations thus far. And overall, the market's saying that's a net positive. Likewise, on an incremental shift towards Medicare privatization, I think it's a stretch to use the word privatization. It could just mean faster growth for Medicare Advantage. I think the market's reached that conclusion as well, and directionally I would agree with that. And then I think where the market has thrown up its hands is on Medicaid and the Medicaid expansion, and said, you know, we just don't know, and we can't assume that that one's necessarily safe. And so that explains the depth of the selling that you've had in the Medicaid managed care names and also within some of the hospital companies. Just finishing this off also on antitrust policy, just incrementally, that maybe antitrust policy will be a little bit more lenient under the next administration. So you saw the market shift in that direction as well, bidding up the stocks of M&A target companies, Humana and Cigna. And then, yeah.
Can I just interrupt?
Go ahead,
1 second?
Cheryl.
That's an interesting point, because I used to work in antitrust, and I worked there during the Reagan administration, and I can tell you as a staff member it was impossible to get anything through the administration. I mean, you could challenge it all you wanted till you were blue in the face and it wouldn't go through. But isn't it a little bit challenging for these companies that the trial date is so soon?
Yeah, no, I don't disagree. I think that's, my point is incremental, not necessarily a conclusion that the landscape has changed with this election, because in theory, at least, the process should be worked out or fully worked out by the time we get to the actual change of administration. You're right, Cheryl.
I think one last one is the pharma stocks, which we didn't talk about, none of us cover, but they have seen a massive rally. There was huge concern on drug pricing, and it's very much market consensus at this point that this administration will, at the very least, back off on some of the drug pricing policy pressures that the Clinton administration could have been putting on these companies. So it's pharma are now the winners and the darlings, Medicaid HMOs and hospitals in the doghouse. I think Medicare and the other HMOs are starting to show some nice movement up as well.
Okay, thank you. I have some questions about scenarios for what the individual health insurance market would look like under just a plain repeal of the Affordable Care Act or a repeal and replace. So if budget reconciliation is used to repeal those parts of the ACA with significant spending or revenue implications, what impact would that have on the non-group market?
Let me just, if I could take a quick stab at this, Paul. I mean, if you think about an impact where what you primarily take away are the subsidies and the individual mandate. If you take those two pieces away, you're going to have something that looks like the impact on, let's say, the New York State individual market when I say we because I'm a New Yorker, when we went to guaranteed issue with no mandate. So you spiral downwards from the 17 million covered lives today to some significantly smaller slice of coverage that is very expensive coverage, but it is available for people who need it in an emergency.
How long will it be available?
I might disagree on that, though, a little. I think maybe I'm just overly optimistic about this. But, I think my view is that the ACA tried to simplify two problems, or maybe three, all into one. One was about uninsurable people because of pre-existing conditions. The other was low-income folk who didn't have subsidies, and perhaps the young and healthy who thought they were so healthy they didn't need to get in. And this idealistic notion of a balanced risk pool that can be created with subsidies and a mandate, and then you can bring all of this adverse population all into one pool, I think is nirvana that no one would ever attain. Now, I'm not saying that there weren't things that could have been done differently, but I don't think we would have ever gotten there. And the notion of bringing back state high-risk pools, and I was going through the Ryan white paper, I think it's A Better Way, I think that's what it's called, and they talk about the state high-risk pools. I think they say it's at least $25 billion in funding. I don't know that will quite do it, but depending on how much they fund those up by, you're at least separating out this this really adverse population and from this notion that the young and healthy would then be able to balance this out. So you take care of one problem. The second thing they're suggesting is the community rating bands go back from 3 to 1 to 5 to 1, and in New York.
Let's hold off on that one until we
Okay.
finish the simple thing.
Sorry. Okay.
Just repeal, sign and or replace.
Because I think Matt brought up the point is that reconciliation repeal is probably not only will lead to the people who needed the subsidies not to be uninsured, not to be able to gain insurance, but also many of the others who were already using the individual market, it's probably going to be a less useful market for them.
So I'm more of the hospital analyst here, and my colleagues are more of the managed care analysts here, so let me maybe give it from the provider side a little bit. We've had a lot of experimentation with individual insurance, and I think the New York market example that Matt gave is a very, very good one. You can try the high-risk pools, and that certainly will try to carve out, those who have had continuous coverage versus not continuous coverage. And a lot of this is going to be definitional. A lot of this is going to be I would say we're almost in uncharted policy territory when we talk about some of these things. There might be some experiments from some states that might provide some good insight and information. But the fundamental thing is we had an individual market before. It didn't work. It was expensive. And there's fundamentally nothing's changed. If you repeal it in its entirety, what do you go back to? You've dismantled the individual market for all intents and purposes. You're going to have to now put it back. Yeah. in some way, shape, or form. The opportunity, when I try to do something that other than wearing black and be a little bit more, optimistic about it, is that maybe we can get some more things right this time if we try to structure the individual market. But the fundamental problem you have is insurance is expensive because people who buy it are sick, and companies need to stay in business. So my comment is, everything that we are talking about here, even if you're talking about unfettered competition, as soon as you talk about guaranteed issue and affordability in the same sentence, you have an impossibility theorem. Doesn't matter what they do, the market won't work.
Okay, well, why don't we move on to the next question, which is, let's say we're talking about repeal and replace. And, what I've heard about replace is that there should be guaranteed issue at community rates. And so the question is, what else would be needed to have a viable individual insurance market? Now you might.
Now I can
The
say,
ACA.
So I think the high-risk pools, I think, are great. The community rating bands, widening the community rating bands to 5 to 1, I think makes a lot of sense. The New York market that Matt, you alluded to, has, I believe, a 2 to 1 community rating band, which is very challenging. Age is correlated with disease, so it gives insurers at least some recourse to underwrite for illness, if you will. I don't think the mandate has worked, really. I don't see any evidence. From 2014 through 2016, we've had 28% of people between 18 to 34, which is the golden band, age band. We haven't seen any improvement. There are hopes, I believe, that as the individuals start to see the 2.5% hit their tax returns, you might see some improvement. But it's the carrot that works. It's not the stick. And so, the subsidies being taken away will shrink that market. But when I look back to what that market size was before the ACA, it was like 15 to 17 million or something in that range. Now we have almost 7 million in the off-exchange market and less than 10 million in the on-exchange market, 8.5 million of which are subsidized. So the market shrunk despite all these subsidies. I don't know that we can kind of reverse the whole train completely, but I don't think that, the proposals that are being put out there are that unrealistic. The market's failed, and there's a reason it's failed, and something needs to be done.
Yeah, and I'm not sure the market has shrunk because you're not counting all of the non-compliant plans that were grandfathered.
That's in the off-exchange market, though,
No.
I think. No?
No, usually what's counted in the off-exchange market is the compliant plans. So you have this whole world of grandfathered and grandmothered
How
plans.
many are those? Do you remember?
I don't know.
Well, if I could just jump in, not that I'm the official arbiter of numbers, but I'll try.
Sure you are, Matt. Go ahead. We rely on you. Go for it.
So the latest figure out there is 10.4 million on exchange and then 6.9 million off exchange. And of the 6.9 million, about 2 million are pre-ACA grandmothered or grandfathered policies. You put that together, that's an individual market of about 17 million. That's up from about 11 or 12 million individual market size in the pre-ACA era.
I don't think it was 11 to 12, but anyways.
And then how many of those slipped
It was Peds or not.
How many of those might have qualified for Medicaid?
How many of those?
So in the
Four?
prior market,
Oh, yeah.
might have slipped onto There might be a few that
That's
you would have
Sure.
substituted for Medicaid.
That's true.
Can I take a stab, though, at the
Yes.
replace? The interesting, this is definitely seeing the glass half full, and I definitely appreciate your perspective, Cheryl, that people are seeing what they want to see right
There's
now.
no question
So,
they
but let me continue and see what I want to see.
Sure.
If we see what we want to see here, what we could be on the cusp of is, finally getting to a bipartisan, in essence, a bipartisan embrace of healthcare reform, because we had the partisan Affordable Care Act, and now the Republicans are inheriting that with a pledge to repeal and replace, but they will own it, and so they have to take it seriously. And what we could be looking at, I say could be looking at a restructuring where we have an individual market, including the exchanges in whatever fashion they might be renamed, where there is significantly more product flexibility, so that products can be tailored to, let's say, younger and healthier populations. You retain the subsidies in some fashion, although perhaps they become tax credits. You widen the ratings bands, so you take them from 3 to 1, maybe 5 to 1, maybe it's 6 to 1. And then you wrap around all of that risk pools. And you just could end up with a solution there that actually enlarges the individual market from its current size of 17 million because you bring in the healthy segments of the population. And let me throw in one other metric here would be some type of requirement for continuous coverage to replace the individual mandate, along with a stricter policy for the special enrollment periods, if you were to put that all together. Now, that's asking for a lot, I recognize, and definitely seeing the glass half full, but that would be the solution that maybe how it would look.
You know, I'm reminded of something that I heard from a former Republican staffer for Senator Frist, who reminds me every time that leadership changes, you know, it's a lot harder to be in leadership in Washington than it is to be out of favor. And so, you know, it is the Republicans, and that's actually the happiest I've been all day, that it's now the Republicans' problem. You wanted it, you got it, okay, now what are you going to do? So, you know, I appreciate the effort to see this as half full, but I think we need to be pretty realistic that the challenges here that face the ACA still exist, and the solutions that I've heard so far from everyone are just variations on a theme. So it's a transfer of funds from one part of the federal treasury, from federal taxpayers in some way, shape, or form, that subsidizes the high cost of insurance for people and forcing them in some way, shape, or form to buy insurance. And I'm wondering what's going to happen to the Republican constituency when they wake up one day if repeal actually does get, if it does actually get replaced in this way, and they realize it's exactly the same thing, only a different name. So from where I sit, I'm not making any bets about what repeal is going to look like, to tell you the truth. I'm just simply advising people that, you know, to look at the companies from the perspective of best case, worst case, and, you know, here are the plans. Figure out which one you like the best, and that's what you're going to model. But there's real danger in this because there is no guarantee that the Republicans will get it right. There's no guarantee that anyone can get it right because the fundamental problem is that the only ones who want to buy insurance are sick people. And anything that you do is going to compel this group. And what I worry about on the repeal side is you still have a very sizable portion of the House that may not go along with the leadership on any kind of moderate repeal. When you say bipartisan, I guess you can always hope, but you know, you all live around here, you all work around here. You tell me, is there any hope for bipartisanship in this new Congress that's coming up? I can't see it. So, but it also doesn't matter. If anything, I'm much more worried about what is one side of the GOP going to do to the other side of the GOP, whether or not they can even get to agreement. Because from a company, a business, and a human perspective, we need certainty on this. We don't have a lot of time. And the one final point I'll make, and far be it from me to try to help anybody who might want to take benefits away, because I actually think it is a social problem that needs to be solved. But so that's sort of my policy stance. But I am reminded of when President Obama's administration came in 2008 with arguably political capital and a mandate, and 60 votes in the Senate, which the GOP does not now have. And it took them 2 years, a loss of the 60th vote, and reconciliation to get the damn thing done. All right? Now, if I were in the Trump administration, and believe me, I'm not volunteering, I like my job, thank you very much. But if I were in the Trump administration, I wouldn't fritter away that time. I know they're all talking about it being complex. I know they're all talking about it being, you know, a difficult and sensitive issue. Whatever plan they're going to come up with, it's going to be as good or as bad as any other plan because the problem is complex and difficult to solve. So pick one and get on with it. H.R. 1, first bill in the Senate, get it in there, get it acted on, and give the market certainty again. We can deal with it if it's bad news. We can deal with it if it's good news. We can't deal with it, and business pro-business party cannot deal with the uncertainty. Doesn't matter what replacement is, just give it to us.
Yeah, well, let me move on to the final question of this series, which is talk about transition. Let's say we are going to have a repeal and replace, or even, remember the president-elect using the word, modify. So whatever it is, given the uncertainty as to what's going to happen this year, 2017, 2018, are you concerned about holding the insurers who participate in the marketplaces in? Or could it be a real problem if they depart during this period of uncertainty and they're not there for the replacements?
I think they've already departed. I think getting them back in is going to be next to impossible. I don't see anyone sort of raising their hand and volunteering to be shellacked a second time.
I would disagree with that. I mean, it remains to be seen, but maybe you can put United in a separate category, but the plans that have left or are leaving, Aetna and Humana in particular, have made deliberate efforts to keep placeholders on the table. Aetna, for example, is retaining plans in the off-exchange market. As few of them as possible, to be clear, but they're retaining plans in order to have a toehold presence so that they can re-expand once they look at the situation and decide that the market is restabilized and they can make a go of it again. To be clear, unless there's some type of requirement, and I don't see this happening in the current political environment, but a requirement that say you have to be in the individual market if you're going to be in Medicare Advantage or something like that. And you have had some versions of that in certain states, but I think it takes a certain top-down regulatory environment for that to happen, and that doesn't look like the environment that we're going to be in. So you have to go the carrot, not the stick, and you have to fix the individual market or have the prospect of fixing it in a way that makes participation enticing, which doesn't necessarily mean that you get United and Humana and Aetna back, fully participating for 2018. But you've got a lot of plans out there. Most of the not-for-profit Blues are participating. Anthem, the largest commercial public company, is participating. Of course, Centene and Molina. So there is potentially a lot to build on. If I could, just to make one other point though about the individual market and functioning, which is it's not necessarily the case that only sick people want to buy coverage, and I think it is instructive to look at another market where you have selection dynamics that actually work, and that would be in Medicare Part B, because Medicare Part B is an optional program that requires a premium payment. And I think as most of the audience knows, when you turn 65, you're automatically enrolled in traditional Medicare. You're automatically enrolled in Part A, which is free. There's no real opt-out for Part A, but you don't pay for that. Part B requires a premium payment. You're automatically enrolled in that. If you do nothing, that premium payment, which for most Americans is about $105 a month or so, is automatically deducted from your Social Security check. The reason that when people turn 65, they don't opt out of Medicare Part B and say, look, I'm a healthy 65-year-old, I'll opt back into this when I turn 73 and I need health care, is because every year Medicare Part B, if you do that, gets prohibitively more and more expensive. And so there's a requirement for continuous coverage. So you could look at something like that working in the individual market. Now, the one caveat to that is Medicare Part B, of course, is 75% subsidized by the government. So that's a key asterisk.
That's an interesting point that you raised, because even when Part D was initially rolled out, if you look at the Part D rollout as a model for what could happen, as I recall, you had an open enrollment, and if you didn't show evidence of creditable coverage, then the next year when you tried to enroll, it was really expensive. So there wasn't a mandate per se, but there sure were strict financial incentives that made it prohibitively expensive to opt out year one. Now, if you had a pension arrangement that gave you equivalent coverage, or if you had an employer-based arrangement, you had evidence of it and you were protected. But that's an interesting mechanism that could certainly be considered, that if you don't opt in, that's fine, it's your choice, but it's going to become increasingly expensive, provided that whatever subsidies you're eligible for don't cover you for that incremental premium. And you could construct some things like that. And that would be very interesting.
Yeah, thank you. Let me move on to the next section. It's a series of questions about the ACA marketplaces. And, you know, these questions, except for the ones I've asked so far, were made up before the election, shared with the analysts. And when I went through them, there were some obvious things. There was questions on public option that I'm not going to ask. But there were a lot of questions on the ACA insurance marketplaces. My initial instinct was, you know, maybe they're not relevant anymore. But then I started thinking, well, look, this structure is going to function for at least another 2 years, 2017 and 18. And as we've gone into before, if there's a replacement, the replacement might have some resemblances to what we have here. So in a sense, the issues are the same. So I decided that many of the questions are really just as relevant and might be extremely relevant for those newly coming into power to hear, since, as I forget who said it, Mr. Trump and Republican Congress are going to own this. And they're going to have to be very careful in how they build it. So first question is, with open enrollment now in full swing, what seems different this year? What seems different this year are three developments: much larger premium increases, departures of a number of major insurers, and failures of many co-ops. This has led to discussions about market stability and affordability. So the large premium increases for 2017 appear to be strongly based on claims being larger than projected for 2016 than when those premiums were set. When the 2016 premiums were set, insurers had a full year of 2014 claims experience and some 2015 experience, but 2016 premium experiences were modest. And now, of course, we have the end of the reinsurance. That's clearly a factor. But I remember seeing lots of anecdotes from insurance executives about something happened between when the 2016 rates were set and the 2017 rates were set a year later. What were the surprises to the carriers in the experience?
I think they were twofold. Maybe there's more, but at least two major factors. One was the 3 Rs. When they set the rates for 2016, they were expecting the risk corridors to be reimbursed in full. And October was a huge surprise in 2015. And I think that catalyzed the beginning of the end of the co-ops, if you will. That then has carried over into, also we've had claims issues that had not been observed in the 2015 plan year when they were pricing for 2016. And I saw a distinct difference in the tone from all the players, including Aetna and Anthem, who's still on, but the second quarter of 2016, they were complaining heavily about an increased adverse selection that they hadn't observed before. And all of a sudden, the CEOs and the management teams got extremely bearish. One of the drivers cited was the gaming of the system with dialysis companies, for example, that was steering adverse members from Medicaid into the exchange population. And so that was creating a lot of pressure on the claims. I also heard about prescription drug usage that was inordinately high, and they were not getting reimbursement from the second R, which was the risk adjuster. And so you've seen Mark Bertolini from Aetna on a soapbox on every TV show that lets him on about how the risk adjustment methodology needs to be changed as well. And then finally, going into 2017, the reinsurance, which is the only R that ever really saved these companies from enormous losses that would have been even worse than what they're seeing, is phasing out in 17. And that's been quantified as something between 6 and 9% in a rate increase, once you net it out against the fact that they don't pay into the reinsurance pool as far as the premiums go. And so all of these things combined, I think, get you to that 25% on average rate increase, and you've now seen Aetna, Humana, United, and the co-ops leaving. The risk adjusters are not collectible. The plans left behind, like the Blues and Anthem and some of the regionals, are very concerned about increased adverse selection. In fact, even the Medicaid HMOs, which have been the one bright spot on the horizon, are very concerned about risk adjustment payments not working out the way they'd like. And potentially they're hopeful, but they're also worried about adverse selection coming onto their books as well.
Maybe if I could just jump in on the outlook for the exchange enrollment. We're now in the middle of the open enrollment period, which started November 1st and ends January 31st. I think a lot of people are looking at the current administration's projection that the number of signups will increase to a material degree relative to a year ago, as not very credible, unfortunately, given the current circumstances, because I think you've got to look at two sides, and one side, in my view, significantly outweighs the other. I mean, on the one hand, it's true that the individual mandate is now more fully phased in, and you have greater awareness of that and greater awareness of the exchanges generally without all the outreach programs that have been conducted. And perhaps with some greater level of restrictions on the special enrollment periods, there's some awareness of that as well. And that may potentially induce people to take up coverage at a greater rate. But the flip side of it is obviously to point to what everybody knows here, the significantly higher level of premium increases, the significantly reduced level of product offerings, and even within those product offerings, the significantly more narrow provider offerings, provider networks that underlie those products. And I think that those sets of things will, at the end of the day, unfortunately, significantly offset the first set of things, and you're going to see signups materially lower than you would have in the last than we did in the last open enrollment period. The one other thing that's an uncertain impact is the election outcome. Will that impact the rate of signups at all? And you could think about this one of two ways. You could say, well, maybe people are going to rush to sign up because they'd be worried that if they don't sign up, that they'll lose the opportunity to do that, and that people who've signed up for coverage will be grandfathered in somehow. Or will people say, oh, well, now that the Trump administration is coming in with the Republicans, all of this is going away anyway, I'm not going to bother. It's not clear what impact we're going to see there.
Good. Because the departures of national insurers, I want to ask you about your interpretation of what's really behind them. In a sense, is it that the marketplaces were not an attractive business environment because of policies like special enrollments, that the marketplaces are a much smaller market than they had anticipated a few years ago, or that these insurers are not well suited for the very price-conscious consumers in this market? Or a fourth one is the overall political uncertainty that has been experienced. So, what's your sense of the key drivers of some of the national insurers to have departed?
Can I take
Sure.
a first crack at this? So first of all, it is, you take what they said. Let's assume that CEOs of major U.S. corporations don't routinely lie, okay? Especially not in public, which would be different, change, from what we've heard over the summer. So the statements by these companies have been pretty straightforward. The risk pool is not big enough. It's not well balanced enough. There is not enough premium that could be charged in the market to take account for that. The gaming of the system is severe. Sign up when you get sick, get treated, have big losses for the plans, and then depart. And that's not how insurance works. as those of us who understand insurance know. So that clearly was the case, and I think that's absolutely true. And I think Anna gave you a really good example of this entire thing in her first comments about the fact that the risk pool is not well balanced, it's not large enough, the risk cannot be diversified, and it was pretty clear that was the problem. I would take a little issue at the notion of that these companies are not well suited to compete in a price competitive environment. How do you compete in a price competitive environment when most of the people buying insurance on the exchange are subsidized and price insulated anyway? That's number one. Number two, they're not allowed to actually determine what their level of benefits is, and that's a very important tool not only to mitigate their risk, but also to be price competitive. So when you mandate the benefits and you mandate guaranteed issue and you have narrow bands, something's got to give, and it's going to be price. And if you can't raise the price by enough to offset the risk because the actuarial model breaks because the risk pool is ill-defined, then you have to exit the business. And I think that that's just the fundamental problem here, is that the structure of this was unrealistic. And, there was one other element here. So it's not just guaranteed issue, it's the limitation on lifetime caps and the limitation on maximum out-of-pocket. You're really, we said this here once before, that the ACA constructs an impossibility theorem for an actuarial model. You can't ask these guys to have unlimited risk and stay in business. You just can't. It doesn't work that way. And that's why I think the ones who have chosen to exit have had to do that. I mean, there's billions of dollars of losses here that they're reporting, never mind what they've been protected by reinsurance and by other things. So I think it has nothing to do with being price competitive, because we've certainly seen them irrationally priced on multiple occasions often enough.
Yeah, and I think just a couple of examples of this was Anthem was probably the only large public insurer that was very optimistic about the markets all the way through maybe the end of 2015. And then I thought I heard kind of an oops in the fourth quarter of 15, that they may have underestimated the claims and the adverse selection. They've backed off considerably. They're still saying they're losing money in 16. They're hopeful that they get to break even in 17. And most of us who even give them a little benefit of the doubt think, wow, that's a buy. Then now, of course, this is pre-Trump, but if most of the investors are very skeptical that they get to break even in 17. I think right now, as far as I know, Matt may have other ideas. On the Blue Cross Blue Shield side, we've seen a lot of exits. I think Blue Cross Blue Shield of Florida, last I spoke to the president, he was still very bullish. But I don't know if he's changed his mind as well. Other than that, I don't think anyone is really.
Yeah, well, we had a speaker yesterday at a conference that we sponsored, a Global Mizuho Investor Conference in New York yesterday, from Blue Cross of Horizon Blue Cross.
Horizon.
And it was very interesting to hear what they had to say. So right now they're actually making money. And I found that fascinating, and I didn't really have an opportunity to follow up, but I suspect it's because the New Jersey insurance market was actually somewhat functional prior to
Maybe it was more like
reform.
New York, wasn't it?
I thought it was.
Yeah, I think it was already terrible.
It was
so
already
this got it to a
dysfunctional.
slightly
Did I say
better
functional? I
place.
meant to say
Yeah.
dysfunctional. Sorry.
So
It
it
was
was less dysfunctional under the
Less,
AC
yeah.
than it was
Relatively.
before.
or equally dysfunctional, and you learn how to behave in a dysfunctional market. But there certainly were strategies and tactics that they have been able to pursue in the market, and pricing they've been able to get, and probably a high degree of subsidy. Having said that, when presented with this notion of the impossibility theorem of guaranteed issue unlimited risk, and some of the things that have been just the broad strokes discussed in the very early stages, which clearly are not the final formative thinking of the administration to come, they would be very nervous and likely to not expose their other members and their mutual members to those losses. They are basically saying we're out. So there's a lot at risk here. Good credit to the Blues for staying in, losing money and hoping for the best, but there has to be a limit. It's not, they can't write a blank check of transferring income from insurance companies to the federal treasury. It doesn't work that way.
I would agree with you, Cheryl, particularly on that last point. I mean, I think you are at a precipice here, and it wouldn't take much to throw this into a tailspin,
Right.
where, a scenario that is not all that unlikely, where enrollment is down, pick a number, 20, 30%. Maybe it's not that much, but that could happen. And then we get into early next year, and some of the public companies, probably before others, start to recognize that things aren't turning around and they're in fact getting worse. And then you have a snowballing of exits. And I say snowballing because there is a fear of being the last plan standing in these markets. And look, I mean, in that scenario, you'd be looking at a complete unwind. The only good news there is that because you'd be looking at a complete unwind, it would demand a solution.
And might be easier to replace in that sense. I mean, you know, just stepping back for a second, so I don't think any of us are arguing that the construct of the exchanges under the ACA was a healthy marketplace. So I don't want anybody to go away from, you know, my comments in particular saying that I'm defending the ACA and it should stay the way it is. No. What I am saying is it sort of is what we have. It's not perfect. It's not great. There are people out there who needed this coverage, who want this coverage. We agreed to take care of them. So, you know, there is something of a social contract here, but there's no question the exchanges are deeply flawed for a lot of reasons. And what surprises me more than anything else is that it took the companies as long as it did to figure that out.
Yeah.
Good points. Let me move on to a few questions about the insurance mergers, and I'm talking about the large national mergers. To what extent are these proposed mergers, you know, Anthem and Cigna, Aetna, Humana, and the already approved Centene with Health Net, a response to company-specific issues or to broader changes in healthcare financing and delivery?
I think it's a bit of both. You know, it's a bit of both. There's challenges with what we've seen under the under the Obama administration in the last 8 years, and some clear shifts that were broader into your moniker of broader changes that have sparked this. But there are also some very company-specific factors. As far as the broader changes, I think just the ACA, having medical loss ratio floors, incredible tax headwinds. I mean, when you look at the P&Ls of these companies, it's just astounding to see the tax rates. And when you compare that with the rest of healthcare or otherwise, they're very unfairly being punished here. And I think that put a lot of pressure on their earning streams. They've pedaled hard. The public large companies have tried to make it, but you know, you get synergies. When you get to the opportunity side of that ledger, you get synergies, fixed cost synergies. Clearly, they'll guide to those. Medical cost synergies, which they're far more cautious about saying anything about, but it is a huge impetus for merging with one another to get more negotiating leverage at the table with the providers. So I think that's the other piece. Specifically around Aetna and Humana, and Aetna must be really salivating and hoping this trial is successful at this point under this new administration and the GOP sweep, because they did it heavily because they needed to diversify into Medicare Advantage. And Humana is the prize there. So that was clearly the impetus on, in addition to all the cost advantages. As far as Anthem, it was about the employer market. They're in 14 states. They don't have a national footprint. Cigna brings them that, not perfect, but it at least gives them some independence from the Blue Cross Blue Shield Association in trying to cobble together a national network for the national accounts market. And then in the select market between 50 and 250 employees, Anthem was losing a lot of market share to Cigna and continues to, from the fully insured side to self-insured and stop-loss. And I think they're looking to have a full-service solution for employers of all group sizes with the merger with Cigna.
If I could just throw in one note on that, I mean, I would look at it maybe a little bit more simply in terms of why they merged, and I'm not disagreeing with all of the individual reasons that may have influenced the particular mergers that happened. But in general, these are for-profit companies, and in any industry with for-profit companies, the tendency is what do they want at the end of the day? The best environment for a for-profit company to be operating under is one in which it's a monopoly and it has very high barriers to entry. That's a perfect business environment. So companies left to their own devices are going to merge into that configuration until they're stopped from doing so. That's just to simplify it to
correct.
its essence.
I would agree with that. You know, I'm also reminded of a couple of things that were said along the way. So I remember when the deals were announced and not covering any of those four, I won't comment on the prospects for those companies, but I'll just make an observation. There was a notion that the Obama administration and the ACA somehow was predicated on further consolidation of the managed care sector, that it was supportive of it and that it wanted it. So you can imagine the rude awakening when the DOJ actually started to talk in terms of challenging these things. You know, but I'll just sort of move the discussion along a little bit. These companies have made some pretty cogent arguments for why they need to merge. And the other thing that you do, what's hidden here is, you know, you want to build scale because scale is more efficient in this business. It is a scale business. So you can also add that to the litany of reasons. But they've been explaining to their investors why these are mission critical things that they need to do and even take to court to challenge, to prevent the DOJ challenge. And that's obviously something that's pretty unusual to do. If they don't get to do these deals, now they have to go back and recreate themselves. And they have to deal with an investor base that says, okay, you just told us how mission critical it was that y'all merge, and now you're going to come back and tell us how mission critical it is for y'all to be independent and how great a job you're going to do. So I think this is make or break for these companies in that sense, in terms of what their thesis is, what they're going to need to have in order to succeed going forward. You know, probably the best thing they could do is ask the judge for a continuance until the end of January, because I suspect a new DOJ will be a whole lot more interested in hearing what they have to say.
And they fought for the scheduling hearing, they fought for it to happen at the
early.
end of 16.
Yeah, to happen early. So that may be a decision that they regret, but who knew?
Well, I'm sure we talked about these mergers a year ago. And, you know, as a result of a year and a half of consideration of these mergers, is there anything that's clear to you about the impacts on, you know, healthcare purchasers and providers of these mergers?
Well, I think providers, I said, I do believe it's going to give them more negotiating leverage. I think that's a very taboo thing to say, and obviously all of the provider lobbies and associations that send millions of letters to every state attorney general and the DOJ didn't do it, you know, just because they were trying to help the Department of Justice. So that's where I think this goes on the provider side. On the other hand, I guess, you know, you got to look at it in context of also the value-based care trends, which we've all you know, talked about, and not sure whether and to what extent this new administration and Congress will foster that. But a larger company, and maybe across Medicare and commercial, particularly with Aetna and Humana, I think you could bring some of these principles through CMS into the commercial arena, and, you know, conversely as well, from commercial back to Medicare. So I think there's some value add there potentially for the providers partnering with companies that have a more diversified and a larger book of business at scale. As far as the purchasers, I think they will be under pressure to put you know, some of those savings back through to employers and to consumers. And you still have medical loss ratio floors, so they are capped in terms of their medical underwriting margins. And as far as I can see, the Bill HR 3762 does not repeal the medical loss ratio floor. So most likely it looks like they're here to stay. So, you know, I would think that there's some value for the customers in the deals as well. But, you know, they're going to let a lot of it fall to the bottom line. And obviously we as analysts have baked that into our estimates of those deals close.
Good. Next questions. This is about leverage between health plans, providers, pharmaceutical companies. Is there a trend in whether plans or providers are gaining or losing leverage?
So there's an interesting development with Tenet and Humana, for example, being at odds. Tenet is out of network with Humana right now in Florida. Actually, I think nationally, but certainly in Florida. And, it's going to hit their volume, and they've got a pretty smart managed care negotiator who was raised and trained at United Health Group, so he certainly learned the tough and rough way to handle these negotiations, because United tends to be tough and rough with the hospitals. And, we'll have to see how that works. So if that's a sign of the times, it's one data point. I would say that these are never easy negotiations with the hospitals. I think there are issues around the hospitals acquired a lot of physician practices for a variety of reasons, and they have been trying to get their hospital managed care pricing for their hospitalist and hospital employed physicians for these new groups, and the health plans have been trying, it's just a step up, it's just an increase in margin for the hospital. And the health plans have been trying to push hard and back against that, and so the hospitals haven't always succeeded. I would say, there hasn't been any real evidence of a change in tone, but the tone hasn't been conciliatory for a long time on the hospital side. What I think is going to be really interesting, and where there's going to be more of a battleground, because there's already been a lot of finger pointing, has been on the issue of pharma pricing for, like, the EpiPen is sort of the classic case of this, where there's a lot of finger pointing back between the, not so much the health plan per se, but the PBM. And that dynamic of, the lack of transparency of how PBMs make their money versus the very great transparency of how big pharmaceutical company margins are, is going to be a bit of a battleground, I think, going forward. As the PBM contracts begin to shift from we're making money off of rebates and we're making money off of spreads to perhaps some other value-added services that they can define, it's not all about price, then perhaps that conversation can change a little bit. But that's an area that I think we need to watch. I would suggest that pharmaceutical companies understand that the pricing issue that went away was the headline and Twitter issue. The fundamental pricing issue that when you and I go to the pharmacy, because formularies have changed, because our out-of-pocket costs have risen under these new formularies as the health plans are trying on behalf of employers who are their customers, as the PBMs are trying to control the total spend for their customer, the employer, we are paying more of our drug costs, and we're seeing more of this very high costs and increases. And so because that's a consumer-driven item, that's probably not going to go away as a topic, and it's probably not going to go away as a pressure for the pharma companies. On the flip side, though, there is some talk about increased support of research and development, so the biotech companies are happy, the spec pharma companies are confused, but they're still feeling the pricing pressure. And the PBMs are probably going to have to look at being a little bit more transparent. Do they have to give up margin or not? We'll have to see. But I think because this has nothing to do with which administration is running things, this is a constituent services, hand in the pocket, pull out the wallet, pay the money issue. I think it's going to continue to be an issue for everyone in the system, from the health plan to the PBM to the pharma manufacturer, the distributor, all the way down to the consumer.
I want to follow up on the PBM. It's always struck me that the fact that some major insurers have their own PBM, and they are going to make rather than buy those services, implies some really serious problems in the whole nature of contracting between plans and PBMs. Does anyone have any more thoughts about, how this PBM relationship, as intermediaries between the plans and manufacturers might evolve?
So is the question about captive versus standalone PBMs, or whether an insurer should have a captive
Well,
PBM
not so
and the
much,
drivers?
Yeah, in a sense, it's, why do they have captive
Yeah.
PBMs? I've always thought there was, not a sense that making it was cheaper than buying it, but because it was so difficult to have a contract with PBMs that they had confidence in. And, when you look at the Anthem suing Express Scripts on that.
Well, let me take a crack at that. I think just back to a very fundamental, high-level principle. Why does managed care exist? They exist And it's been reinforced by this administration to moderate healthcare costs. And they've been doing that for hospitals, and at least in the last several years, it's been going quite well on the the outpatient inpatient side. I think in the ideal state, they would like to be that intermediary entirely for the pharmaceutical side as well, and tried to do that. In 2006-07, when Ron Williams was CEO of Aetna, he had a very strong vision of having a vertically integrated PBM within the company, and I think the whole notion of outsourcing would have been anathema at the time. What happened, though, unfortunately for the insurance companies, is they lag considerably in scale on the number of adjusted scripts compared to a CVS or an Express Scripts. So the kind of discounts that they get with the pharma manufacturers is severely disadvantaged, and they could never quite succeed with that kind of a scale disadvantage. They had issues with their script filling, their mail order facilities, to the point that even their employer medical benefits contracts were getting threatened because there was quality issues in terms of how the script filling and so on and how that went. So Anthem was the first, and it was just a complete reversal of the kind of, the vision of having a captive PBM in 2009. They, I think, also had sanctions, if I remember right, in Medicare on their Part D, and they outsourced the whole thing in a very big way to Express. And it took some time for Cigna and Aetna to come to the same conclusion. They're definitely more along the lines of, what I would call retain the brain and outsource the brawn. So they have the formularies largely in-house, the customer servicing is in-house, but they're outsourcing the discounts because they're trying to play catch up, and they cannot live at that kind of a disadvantage. And they're outsourcing, in some cases, Aetna is on the mail order side, and Cigna still hasn't done that. The world has changed since then, and I think now we have the plans have had more script fills, particularly United and Humana, who have an organic source of script growth with Medicare Part D. And United showed this. They finally got to a point where they had adequate scale to get decent discounts, then did the Catamaran acquisition and successfully brought a full-service PBM, not just to service their own book of business, but third party. And that's created, I think, PBM envy, captive PBM envy. In the rest of the book, I think Aetna and Anthem would clearly like to do something different, hoping the deals close so that their script fills and their volume gets substantially expanded, particularly Aetna, where Humana has the Part D, 450 million scripts or something, which just enormously gives them a scale advantage. The other thing that happened, I think, is that the specialty drug trend overtook all the small molecule side, on the branded side. And finally, the plans now, I think, feel that with physician networks, they have specialist networks where they have an advantage, and they could do something different. And they're beginning to deliver that, and Optum is showing that, and Anthem is showing that, despite the fact that they outsource their PBM, at least as far as the more commoditized functions, to Express.
So can I just, a couple things. First of all, Anna, you are lucky that you're not as old as I am, so you won't remember this.
You may be surprised.
I'm old. In the late 1990s, I believe it was 1998, United Healthcare, as it was known at the time, sold Diversified Pharmacy Services, its PBM, and exited the business. So they actually had it and got rid of it. Not quite sure why. And when they did the PacifiCare acquisition, they had a small company, Prescription Solutions, that was doing the Medicare Advantage, which actually one of their leaders, a female executive, fought tooth and nail to convince them to keep. And why is it so important? I'm going to take a little bit of a different tack on this. If you want to look at fixing the healthcare system, you have to be patient-centered. And if you're going to be patient-centered, you cannot leave off the single most frequent interaction with the healthcare system a patient has, which is at the pharmacist's desk, from your consideration of the total 360-degree look at the patient. And by integrating the pharmacy and the pharmacy data, real-time, synchronized, and I hate the way that words get used, but completely integrated. And they have this massive data lake where they know everything, and it's all buried down there. But pulled it all together so that when you have a patient who all of a sudden pops up as being, wait a minute, this patient actually could be really sick, or this patient actually, why is that patient on that drug? It's not just drug interactions, but more than that. Then you can intervene to make sure that that patient's getting the health care they really need. And that's where the real cost savings comes from. So if you're thinking about this far into the future, assuming that not just value-based care, but transforming the healthcare system so that you're focused on doing the right thing at the right time, in the right setting, for the right reason, at the right cost, you can't just have a piece of pharmacy there and a piece of primary care there and a piece of acute care there and expect the managed care company to be able to manage all of those pieces simultaneously. If they're really going to manage care, it has to all be integrated. And I think that's the vision that United has, that the others may or may not have, but if you don't have all the pieces and they're not already integrated and sitting on top of the same data and the same technology and the same analytics and the same ability to predict that someone who's on this drug is going to have that disease, you're not going to be as far along. You're going to be playing catch up. And I think that's the actual risk of the distraction of these mergers, is that these companies are going to end up playing catch up to where, other things equal, assuming that the election results don't change anything, where United's trying to drag the market kicking and screaming.
Yeah, so you're saying that with an external PBM, you just cannot have that level of
You
integration?
you can't be as tight. It's not just the formulary, it's the active care management that matters.
If I could just jump in for a second, though, I mean, I think the question that you're posing here is, is there a role for smaller plans? Can smaller plans be viable in the current environment? And I think, we don't know. The answer is probably they can, and particularly integrated plans. We're talking about integration, but, plans that are integrated on a smaller, more local scale, will they continue to have a role? The Geisingers, I was going to say Group Health of Puget Sound, but they were bought by Kaiser. They don't have the scale to run their own PBMs. Now, they can run some of those functions, so they have to rely on virtual integration. So I wouldn't disagree with your point about integration, but they need to rely on virtual integration, and they need an intermediary to contract with, and they may want and demand that that intermediary not be an Optum, and that it be an entity that's independent of being a plan that's competing against them. We'll see. This is, the lines are being...
That's been the argument about Optum for a while, that they wouldn't be able to succeed because they were owned by United, but meanwhile, it's an 80-some-odd billion-dollar company. A significant portion of that is outside, and the outside business is growing, but there will always be people who will never trust someone who is owned by the competitor.
Right. I will say PBM is potentially... we'll see. This is being tested right now, and I'm not going to try to rush the conclusion, but PBM is a different category from some other services that it may be that health plans are less willing to buy that from a competitor than they are when it comes to other services that are maybe more distant from the core function. So I guess what I'm suggesting is what we're seeing is a bifurcation here, where the largest managed care companies are inevitably going to running the PBMs in-house, but that there's a whole nother segment of the industry which, unless it washes away, is going to be relying on virtual integration. And the good news for virtual integration is that every day, as technology gets stronger and stronger, you can do more and more of that virtually without necessarily having everything in-house.
Good. Let me move on to one more topic before we go for our questions and break. This is about spending trends. We've had years of relatively low spending trends, particularly in Medicare, and that's triggered debate about the importance of the recession and the slow recovery versus other factors that may prove more durable. So from your perspective, what are the key factors behind the last few years of relatively low spending trends?
I think the biggest one in 2008 after the recession is, and now it all seems so obvious and we hardly talk about it, is the adoption of of high deductible plans. There was not a big trend at that time, and there's been a huge increase in penetration, and that's driven down utilization. It continues to. I think there's more opportunity to increase penetration, even though maybe the size of the deductible may not increase that much now that potentially, the Cadillac tax has been at least delayed and very likely will get repealed even before the whole Trump thing happened. I think on the other side, and this year has been a big kind of it seems like, and maybe Cheryl and Matt have, of a different perspective. But my sense when I talk to the hospital companies in the last few months is that they're all of a sudden waking up to this notion of lower cost sites of service, and it's beginning to hit their volumes. I think it was masked by the Affordable Care Act. They had a lot of volume from Medicaid expansion and exchanges, and it was hard to tell, is this the ACA or is this something else? And after the ACA tapered off, now they're talking about mix shifting, not just from hospital inpatient to hospital outpatient, but heavily to freestanding ambulatory surgery centers. And Optum is building out these regional kind of compacts around a primary care delivery system with urgent care and with freestanding ASC and owning hospice, anything that's not hospital related. And so that mix shifting is leading to a lower effective unit price equation, and it's moderating the spending trends as well. And then the third one, I think, is the whole notion of value-based care, which I think is probably more in the nascent stages, in the early stages. But you are seeing a move from fee-for-service to fee-for-value, and that's also driving different behavior on the provider side. And remains to be seen if CMMI survives in its current incarnation and what the new regime is likely to do. But it feels like on that the train's left the station, and with the more fiscally conservative policies that we'll see, I don't think that we're going to see much of a pullback on that as well. So all of those things together make me optimistic that spending trends will remain moderated, that it is structural, that it is not purely a cyclical phenomenon. We are seeing a bit of a rebound from just pent-up demand, particularly in the orthopedic side, hips and knees. But a lot of those procedures are taking place in an ambulatory setting, which is like 25% of the cost of an inpatient, 50% or so of an outpatient setting. When I look at the Tenet P&L, which has an inpatient arm and the outpatient on the hospital side, and an ambulatory arm with the recent JV they did with United Surgical Partners. It's so clear that even though they do well and the strategy makes sense, it's going to take a while before the cannibalization of their higher priced business will work itself through that P&L, and they'll actually see some growth in EBITDA.
So there's a couple of interesting things, and I don't really disagree with anything that Anna said, but let me just give you a couple of things. So first of all, it's called Optum Care, and it's built around primary care practices predominantly, and it is all about patient-centered care. It's all about right care, right time, right place, right reason, right cost, at the right price, rather. And it is expected to be one of the single biggest contributors to United Health Group's Optum business over time. And the doctors are all in. And not everybody who applies to become an Optum Care physician actually gets in, which I think is kind of interesting because you have to be willing to change the way you practice medicine, which, if you want to talk about bending that cost curve, that's how you do it. So that's part one. Part two is I'd like you all to pay attention, for those of you who are kind of metrics driven. Look at what's happening to ER visits and the rate of growth for the publicly traded companies and for hospitals. The emergency room is known as the front door of the hospital. Between 60 and 70% of admissions actually start in the emergency room. You roll in and you end up in a bed. 60 to 70% of the beds are filled with those ER patients. So obviously when those ER patients are no-pay patients, when they're uninsured, it hurts your P&L. When they're insured, it helps your P&L. Just back to that original conversation we were having. So just keep that in mind. What we're actually seeing, and what we saw in the fourth quarter of 2013 was really interesting. Remember, fourth quarter 2013, for the last quarter before ACA enrollment started, was that the growth rate for several of the public companies in their ER visits, same store, year over year, was negative. So it dropped. And then you had this ACA spike, and it's absolutely blindingly obvious. If you plot it out, it just goes straight up and comes straight down, and it's very narrow over a period of roughly 8 quarters, maybe 9. And then second quarter of this year, third quarter of this year already reported, you started to see a very precipitous slowdown in the rate of growth of ER visits. And the companies are attributing this to freestanding emergency rooms. But if you look at who's doing freestanding emergency rooms, there's a public company called Adeptus who's had to change their strategy because our good friends at Managed Care realized they were being price gouged and they're not going to be paid for these things unless they're attached to an emergency room, unless they're attached to a hospital, and they're certainly not going to pay those prices. So I find it a little bit hard to believe that this rate of growth is because of competition. I think this is the canary in the coal mine. And the one reason that I'm optimistic for our society from a healthcare perspective is that if we are really moving to this model of right care and avoiding the emergency room, because we don't need to be in the emergency room unless it's an emergency, that the hospital model is changing very dramatically. So since 2006, I've had this theory I've called starvation in the land of plenty, which is lots of old people, no money to pay for it. We are there. And in addition, now what we're seeing is the structural change of where we are being treated as technology, as philosophy, as policy coalesce around less inpatient, where you get sick, where you're exposed to infection, where the care is challenged oftentimes. These are not necessarily efficiently run operations versus outpatient, go home. So it's very clear that we need to watch. This could be the start of some very significant declines in utilization in one of the highest cost settings. That's point number 1. Point number 2, post-acute. So Kindred recently reported their earnings. They operate in facilities in the post-acute setting, plus they bought a major home health company a couple of years ago to try to offer an integrated post-acute continuum to deal with bundling from CJR. And they're exiting the nursing home industry, provided their landlord Ventas will let them, and they're letting them, but they have to sell some facilities to get there, and that might not be so easy. So what we're already seeing is the utilization of high-cost settings is declining, and that's very, very important, and I think that's a sea change. So I'm optimistic from that perspective. And the final thing I'll say is this is actually a bipartisan issue. And while that might be a little surprising, just think about the budget equation. Per capita spending times the number of capitas. You can't make per capita spending 0. You might try, but you can't make it 0. So even though it's coming down because we're being smarter about where we're spending our dollars, and also don't forget sequestration and a lot of other things that caused it to come down, but fundamentally, the number of capitas is going to rise so quickly into that part of the population. This is the same story you've all heard. Baby boomers like me, we're going to take all the rest of you for a ride, and we're going to spend your money, okay? Because we're all going to be sick, and I'm doing my best to get there, okay? I got to get some benefit. So the only way we're going to be able to handle this is the per capita spending. And you can't make price 0, so it means you must attack utilization. It's got to be smart. It's got to be precise where we get our treatment. It's got to be effective. So watch all of this business about doing these joints outpatient, because if you look at the readmission rates from the outpatient joints, your total cost of care may actually be a lot higher. So we need to move from per event, fee for service, to episode of care. And that's what we're doing, and where we're doing it, we're successfully seeing the compression of spending per capita.
Matt?
Yeah, no, let me
Go
just
for
just chime in a little bit. First of all, Cheryl, I think I agree with what both of you said directionally. I think you're a little bit overly optimistic.
You had to be there.
What's your reading, Matt?
So I just let me just speak up for the cyclical side of this, which I definitely agree that all of these secular themes are at work here, but the cyclical side of it is important too. And I think it's important to look at some of the broad trends, and the model that we followed, which originally I think was developed by Milliman, is one in which we find healthcare spending slowing for a period of 3 to 5 years in the wake of each recession. If you look back 30 years, 40 years even, you can see actually a remarkably strong, statistically significant relationship along those lines with the regression model. And, so exemplified by trend bottoming in 1986 after the 1982 recession, bottoming in 1996 after the 91 recession, and less dramatically, but I think still the case, bottoming in 2006, 2007, 2006, I suppose, after the 2001, 2002 slowdown. And then finally, and the large companies agree with this view, that trend on a per capita basis, leaving aside the ACA, bottomed in 2013 following the 2008 recession. Now, why is this? It's just some wild coincidence. I mean, you think about the delayed and lagged responses by employer purchasers. As you go into a recession, first of all, employers often aren't aware that they are in a recession until it's over or nearly over. And in the context of that, they're feeling significant bottom line pressure. They look to cut costs across every category. Employee benefits is something that they attack using whatever happens to be the cost containment mechanisms du jour. So 25 years ago, that would have been managed care. Today, it still is, but cost sharing has taken its place maybe as the key mechanism. And all of that, when employers step on the accelerator to put these cost-containing mechanisms in place, it has a multi-year lag and a multi-year flow-through, and that combines with the cycle of the weakened and then recovering consumer and helps explain why you have these multi-year lags. And we think we're seeing that play through again today, though not necessarily with a big resurgence on the other end of it.
Thank you. We've got a few minutes of questions before our break. Please wait till the microphone comes to you. And yes, sir.
Sergey Kosteyev, Financial University, Moscow, Russia. I have two very short questions. First, are any state exchanges which are doing well, for instance, California maybe? And if yes, could those states enact their own exchanges if Obamacare gets repealed? Thanks.
Yeah, California is doing better than the other exchanges, no doubt. I think Peter Lee is, and as you all know, done a very good job and is the poster child for how you can get an exchange like this up and running. They've done a good job of bringing in the sick and healthy. I believe they did not allow the grandmothering of the non-compliant plans, which helped them with a more balanced risk pool. So. They are an example of an exchange that that maybe then the Republicans need to consider is that the model for what the others could be. You all are the DC folk, and obviously we've been trying to get intelligence from what might happen. And one of the things I've heard is that Republican governors who apply for 1332 waivers may get more, maybe given the flexibility to try things on their own. Now, however, if you repeal all of the funding sources and just defund the ACA, which it appears the dry run reconciliation bill did across all the consumer and the industry fees and taxes and the dish cuts to the hospitals, and how do you fund it? That I think becomes the question. But is it possible that they could work? Maybe.
Yeah, next question. Yes, Mike?
Thanks, Paul. Mike Miller. I'm a health policy physician and actually lived here and then in Massachusetts during Romney Care, when in fact then moved back here, and actually pre-ACA had trouble getting insurance back here because the market had changed. So I want to follow up on his question and say, is it possible if everything rolls back from the ACA to our prior world, pre-ACA, that other states may look around and say, we don't like the new world and want to try and replicate what Massachusetts had done in Romney Care beyond just the exchanges, and which in theory they didn't need the more money that the ACA put into it.
They just needed the stable funding that they had.
They had, there were obviously would be blue states that are more wealthy, but creating more divisions.
This is an interesting thought. So just how hands off will the federal government be under GOP control of both houses and the White House? And it's a really interesting question. I mean, the whole theory about Medicaid block grants, for example, is, hey, it's a state, all healthcare is local. Give all the power to the states, let them decide. They know their people, they understand their markets better than we do. The federal government shouldn't be mandating. So, I mean, that's why I think Matt and I kind of looked at each other, and Anna was the only one of us brave enough to answer that last question, by the way, you'll notice, is because I think the right answer is we don't know. It is possible, but we don't know. And you know, it depends how much internal consistency the sort of states can do everything on their own if we just sort of give them something to work with. How much internal consistency there is in that policy and the administration, and there is no way of knowing that now.
Yeah. Time for one more question? Yes, Alice. Someone bring the mic to her?
She just
Thank you, Alice Rivlin Brookings. There's been very little discussion of Medicare, except for Part D, but it's obviously a much bigger deal. In my opinion, Mr. Trump stayed away from it very wisely. Medicare can only give you trouble if you're saying you're going to reform it in a campaign, and he didn't. But Paul Ryan has. And even after the election has says we're coming back to Medicare reform, by which he means premium support. How much is that a wild card if we actually get into a political fight about Medicare? What does that do to the things you've been talking about?
Let me try. Let me just give a try to that. I think my first reaction is I think that's going to end up that the Medicare privatization is going to take back burner because we already have the Medicare Advantage program in place, and so to the extent policymakers on the Republican side can do things to accelerate the growth of Medicare Advantage. And some of that may just mean a Trump administration, how a Trump administration sits on top of rate regulation for Medicare Advantage over the next 4 years. But it might also include things like, for example, a suggestion that the policy be changed that when you turn 65, instead of automatically going into traditional Medicare, you're auto-assigned into a Medicare Advantage plan. That might sound controversial, but of course, that would be something that anyone could simply opt out of if they didn't like that. But that presumably would have a pretty significant impact. I think, though, the reason that maybe it won't be front burner is because Medicare as a fiscal problem, while certainly it is a fiscal faces a fiscal crisis, the sense of crisis has abated to some degree over the last, call it 6 years because of the unexpected slowdown in Medicare spending trend. And so I think that's a reason why you're probably not going to see Medicare be the focus of healthcare policy changes. Now, could easily be proven wrong.
So I'll take it. So that may very well be true, and I'm not arguing or disputing, but if it is a focus. So let's take the if it's a focus, since we're all speculating here because we don't know. So I see a couple of really significant issues here. First of all, one thing that was mentioned earlier on in the year and that I think is really problematic is this whole structure of the call notice and the benchmarking and the complicated way in which Medicare Advantage rates are set. And I would love to see simplification of that process just because I don't understand a word of that letter and I have to spend a lot of time trying to understand a word of that letter. And complicated things tend to not work especially efficiently. So decoupling Medicare Advantage from fee-for-service rates might actually liberate and make it an alternative payment mechanism, might liberate it from both a policy and a functional perspective in a good way. Second, I would say, I actually believe that, if it is the third rail, and if you don't need to touch it, you shouldn't, but there is a significant risk for hospitals and potentially for managed care plans that not only do you see the drive to push more people into Medicare Advantage plans, but also then realizing very shortly that you've now created a monster and your spending on MA is high, you now need to contract that spending. And the more you decouple it from the benchmarking, the easier it is to do that, the simpler you make it to slash. So I would actually be in favor of it to a limited extent, but seeing that as a possibility. Now, from a provider perspective, just give you some numbers. So for a couple of the publicly traded companies, they're kind enough to give us a revenue per inpatient admission by payer type. And managed care, commercial managed care, of course, and this is not acuity adjusted, this is raw, so it's maybe not fair. But with that proviso, commercial managed care is your best payer. They're going to pay you on average for the public companies, between $13,000 and $18,000 a case. Let's just call it, $15,000 or $16,000 a case on average. And then fee-for-service is going to pay you $13,000, and then Medicare Advantage is going to pay you $11,000. So if you take about a $2,000 difference, and it's a sliding scale wherever you start, Medicare Advantage will be on average about $2,000 less. That's a combination of acuity and pricing. And as a result of that, if you just switch those people over, they'll come to your hospital less frequently because they're going to be kept out of the emergency room. They're going to be redirected. They might have better primary care. They might not, but they might. And so they may be lower acuity when they see you, and more of what they do may be outpatient because you've got an interventionist, a managed care plan. Bottom line is, for every number of those capitas that shifts from fee-for-service to MA, you lose $2,000. It's all margin. So it's a very challenging outlook to continue this shift to MA for the provider side alone. Never mind the managed care side, but providers all the way down the line. It's very challenging.
It's actually positive, I think, for managed care if you have a lot of Medicare. And the volume swell will just dwarf any rate pressures that you might have, and the fixed cost leverage that you get will at least keep your margin stable, if not expanding. It's just like the most humongous bull case for Humana. None of us will believe it's happening. I think we're all kind of bidding the stock up on the expectation that we'll have a more kinder and gentler CMS, but I think it's just a huge bull case. And I guess to Cheryl's concern though about spending then getting unbridled for Medicare Advantage. I mean, isn't the point of premium support to move from a defined benefit to a defined contribution hybrid option?
And that's really
right?
scary because then you're going to have uninsured 85-year-olds. Oh boy, I can't wait to see what hospitals do with that.
Okay. I think it's time for us to go into our break. Let's reconvene at 10:50.